Hey guys, this is Hessie. Review number 2 on the fundamentals is where we're still at. So we're going to just jump right in. Leadership. This is about a lumbar puncture position. If you remember, why would we do a lumbar puncture? What procedure is being done? There are certain procedures that could be done with that. Number 1, I think of a spinal tap. 2, I think of an epidural or an anesthesia block. Who would those patients be? A lot of them would be your surgery patients. That would be your C-section patients. What is your role as a nurse? Your role is to keep the patient safe, talk to them, keep them calm. It is uncomfortable. It doesn't feel good. Most of the time they say it feels like a bee sting. Try to help them hold their position because you certainly don't want to twist or roll a certain way. It doesn't hurt, but once numb, they may feel pressure. Do not want them to twist or turn again or make any sudden movements, and due to the nature of the procedure and what is being done and where it is located. Aftercare, for C-section, you know what happens. They're not able to move their legs, and you hope that they are at least numb from nipple line down most of the time, hopefully. For those patients, they'll need a Foley catheter placed so they can't tell when they have to go to the bathroom or anything like that. They need TED hose, SCDs, because they're not going to be able to get up and move around for quite some time. It takes a while for that to wear off, depending on how much they had to give them. We'll need to cough and deep breathe, make sure they use their IS, and that's, of course, per respiratory therapy, but it's also our job as nurses to make sure that the patient's doing what needs to be done. If they have a lumbar puncture, they need to lie flat, may need to keep the area covered, we need to check for bleeding, may get a spinal headache, may need medications for that, a quiet room with the lights dim, may need some nausea and vomiting medication. Who can you delegate to? What jobs or positions can they fulfill? Obviously, they can't assess, they can't report, but they could do, place a warm blanket on the patient if they needed it. They could get them something to drink, a drink of water. They could help them move or reposition in the bed if they needed to. On delegation and leadership, you need to remember again, what is your scope of practice? What is the person's scope of practice that you are delegating to? Are they of the same practice as you? If they're not, then their scope is not as great, or maybe greater, actually, depending. So we need to make sure that we remember what they are allowed to do and make sure that we delegate appropriately so that no one gets in trouble, most of all the patient. With that leadership UAP delegation, again, remember what can be delegated and to whom. Who can assess, report, and teach? Obviously, that should be the nurse. In some states, LPNs can do certain things. You have to abide by your state regulations, and sometimes even your state may warrant one thing, but your institution or the facility where you are employed has some other policies and procedures that they follow also. Who is your chain of command? Who can perform tasks? Who's responsible for the UAP? Document when tasks are completed, document when teaching, reporting, and assessment take place. Those are all things that are very important. Another one that we need to talk about, leadership, democratic leaders, participatory. What kind of leaders are there? What kind of leader do you want to be? What kind of leader gets most things done? What kind of leaders is most effective? In management, what kind of a leader is the best type of leader? It depends on what's going on. What kind of leader will get the most out of the staff? Who is in charge? Remember, again, your chain of command. To keep everyone safe, you may need to enforce rules and regulations. You may not always be liked or loved, but this is the way it has to be, and we are responsible for everyone under our watch. We are responsible for patients most of all, and not only patients but the staff in and about the area, because sometimes we make decisions based on staff safety. Also, some things to remember. Another question we had was on HIPAA violations. You realize that there's major fines if you have a HIPAA violation. We need to remember what happens there stays there. It shouldn't leave the walls of that facility. And if you are talking about it somewhere, you need to make sure that it's done in the right context, it's done with the right person that needed to be. Obviously, when you're giving a report, you are going to be giving information out that is confidential, so you need to make sure that you are somewhere where that it can be kept confidential for the most part. Although they really like bedside reporting now, which if the room is a single occupancy room, that's okay. But before, at Grant, we had double rooms, double bed rooms, and I felt like that was pushing the limit a little bit. But now that they're doing single rooms, it should be good. You need to be conscious of your surroundings. We never know who's listening or who's waiting for us to flub up or make a mistake or report something that's not reportable or say something that we didn't even say. So you need to be careful. Watch your paperwork where it goes. Remember, when you fax things to places, that you have the correct fax number, that you are addressing it to the proper person that it needs to go to. And again, remember, you are responsible for that information once it gets to where it's going. Somebody had to send it. Someone is responsible for it. And lots of times it's I didn't do it, you did it. I did it, I didn't do it, you did. We don't want to get into that, but just make sure that you don't get into those situations if at all possible. We won't have to worry about it. There's mostly a designated shred box or an area where things need to be shredded. Make sure the proper things go in there also, and it doesn't go into regular trash. Another one's leadership assigned central line. Again, where is a central line placed? This is not a PICC line. This is not a midline. A central line is placed differently. It's usually at the jugulars or the supraventricular area there of your chest. So think about what's important in assessment. Important assessment is obviously to assess the site, to assess whether it is working correctly. How many ports does it have? Some are single lumen, some are double, some are triple lumen. With that being said, then with the lumens that you are being used, which ones are being in use, which ones are left open? One is usually designated for blood or blood products, but it can be used if it has to be, because sometimes that's all there is and you have to use it. What can potentially happen? Who would be the person that needs to be taking care of this person? Again, remember, with a lot of your questions, they like to say, for this assignment, you have these staff. Now put them in who would be the best person to take care of this patient. If they're stable and they've had it for several days, that might be okay to delegate it depending on what else is going on. Again, you're really going to have to read the question. You're really going to have to sometimes critically think about a few things and see where you need to be with that. Depends on, again, how long they've had it, how long has the nurse been working, has this patient had any complications, is this patient a patient that only has a central line, or are they a diabetic, are they a COPD, or are they have also CHF, things that we need to be worried about in addition to them just having a central line. What would be deemed a complication for this patient? A complication obviously would be an infection, so we would want signs and symptoms of an infection. We'd want to make sure that we would want to take care of that. We would also want to make sure that we assess the skin around it. We would want to make sure that the patient wasn't causing them pain. We would also want to make sure that we assess their breathing, their heart, all of the things that we would normally assess anyway. So we want to make sure that we do this properly. Again, your dressing changes would follow protocol. If there's something on it or it gets soiled or something like that, if it's bleeding, we would need to report that. How much bleeding is it? Sometimes it really doesn't matter. That site shouldn't be bleeding. And then we need to think about, with the dressing changes, how often that needs to be done. With that, you also need to remember it's a sterile procedure. Any type of procedure of that nature is sterile. We need to make sure that we keep it that way. Again, what is the purpose of doing that? To keep this person free of infection. So, another one that we need to talk about, impaired nurse. What is your actions? Check your protocols and policies. Would we need to report unless you're the supervisor? It depends. Perhaps all it takes is talking to the staff member, or the staff member may go home, that type of thing. Why would you need to report? Because they're a danger to themselves and they're a danger to others. We cannot have impaired nurses working. What makes an impaired nurse? Sometimes it's a matter of what medications did they take before they came to your facility. What were they drinking before they came to your facility? Sometimes, even though they have a prescribed medication, it's probably something that may impair their judgment and they shouldn't use it while they're working. They shouldn't drive. There's harmful things to all drugs, and we need to be aware of those. Depending on what they took, again, it may not show up in testing, but we probably would want to get a urine drug screen before they left, or blood screen. Again, the patient they can leave and forfeit their right of being there, and then probably it will need to be, especially if it's a nurse, it will need to be reported to the Board of Nursing, whatever state you're working in. And also, again, it would have to be reported to your supervisor. You may need security. Lots of times situations can change really quickly, and you have to be aware of that. You have to be aware of your surroundings, aware of what's going on, and what types of things may happen. Next question, disaster, assignment of nurses. Depending on what's needed, you may be required to work outside your comfort zone. You realize that. If you went to the hospital now working as a nurse, even though you're a brand new nurse, you may actually have to work in the ER triaging patients, because that's where they need them, especially if you're in a high acuity area where the COVID-19 stuff's going on. Think about those types of things that would happen. You may be, if you're a labor and delivery nurse, you may have to work on the med-surg floor. Nursing is nursing basically, but again, your specialty areas are going to prepare you for that specialty. But nurses should be able to assess, should be able to report, should be able to start IV, should be able to give medications, should be able to take care of people no matter where you're at, no matter what's going on. And again, disaster areas and disasters make us have to do things a little differently. You may not feel real comfortable, but that is what we do. You may be in charge things you're not normally in charge of. If you remember from your triage system in your emergency section, black, red, yellow, green, remember what those things signify and what they mean. So you need to make sure that we talk, you look at that. Next one, manager, nurse, record and audit medication administration. You need to always have documentation of the right patient, your rights. The right patient, the right dose, the right amount, right dose, right amount, the right route. If your patient has a reaction? What time did you give the medication? Or what time was it ordered? Teaching, if any, and you need to document all of that. If a drug was omitted or a mistake made, again, it needs to be in the system. Most systems will flag you and ask you why it was late or why did you not give it, so that you can go ahead and take care of that issue right then and right there. It is obvious that if the patient's not on the floor, they didn't get their medicine. If they're off for a CT, yeah, we're not going to give their medicine. If they are now NPO for surgery, that's what you would need to put. Late documentation, if they were over at therapy, but you know they're going to be back and they'll be okay without that medication for 30 minutes or so, then you probably need to put late documentation. Patient was in physical therapy. Once arrived back to the floor, medication given as prescribed. What was done for the patient if something was omitted or a mistake was made? Was the doctor called? Was they notified? If there had to be certain things taken after that, what were they, and did you do what needed to be done? If medication was held for any reason, again, you need to document. Sometimes we'll have a medication to be held due to the parameters of their blood pressure. We have an order to hold it. So if you have an order to hold it, then that's what you need to do. Finger stick, if their finger stick's low or if their finger stick's high, there are certain things that we sometimes have to do according to what our scales says, and each patient's going to be different. Each doctor's going to be different. You're going to have to do what is deemed for that patient at that time. Nausea and vomiting, orders need to be clarified. If patient refuses, which they have the right to refuse their medication, then you need to tell why they refused it. Or if a medication was changed, you went to give something and the doctor was in there and said, I don't want that given, I'm changing this, then you would need to write, this medication's being DC'd. Expect new orders, or something like that. You need to also think of legal, safety, ethical things when you're talking about medications, giving medicines, omitting medicines. We need to make sure that we document well, because in 10 years or 5 years, you're not going to remember what you did. You may remember some of your patients. Some of them you'll never forget, but you don't remember everything about them, and you don't remember everything that happened and everything that you did. In certain instances, yes, you will, but for a lot of them, no, you won't remember. So you need to document well. Next, we have a suprapubic catheter care, leadership. Again, where's a suprapubic catheter placed? Where is it located? What are differences from a regular Foley catheter? What assessment's going to be different? What documentation needs to be different? What do we as a staff nurse or the nurse that's in charge of this patient need to be looking for? If pulled out, what would we do? Who would we need to, who would we call? Who would need to take care of things? Also, who would need to be taking care of this type of patient? If a patient's confused, again, what would be some extra measures we would need to take with them to ensure that this suprapubic catheter stays in place, they don't tear it out, and things like that. Things that you need to think about, things that we need to talk about. And again, this is a brief overview of some of this stuff. I don't know how much in depth it is, but that's what I gained from it. So we're going to talk about those things that we have there. Next is hepatitis exposure, HIV exposure. Certain skills that we perform puts us at risk. You know that. As healthcare workers, we are at risk for both. We're going to do certain things to help us not get these or not be exposed. Hygiene is one of them. Standard precautions are used for everyone, no matter who it is. Wash hands and gloves, what to do to prevent a needle stick, We have needleless system now that's pretty much universal, and that was also with blunt needles, like to draw something out of. But there are still some places where you may work that don't use a needleless system. There are still some sharps involved. So you do need to take measures to prevent needle sticks. Throw away sharps immediately if at all possible. We talk a lot about not capping your needles, and if you do, you need to be very careful about how you do that. Again, use your needleless system if possible. Encourage your patients to hold still so no unnecessary movement is made, because sometimes that's what happens. That's how the needle stick happens. Your patient moved when they shouldn't have, and sometimes there's nothing that can be done about it. If you do get a needle stick, you need to go through your proper channels and proper protocol per your facility and do what needs to be done step by step and get it taken care of.